Another thing could be done by the ventilator is recruitment maneuvers, RM. And it's still debatable whether it should be offered to ARDS patients on a regular basis or routinely, but anyway, and as a rule, it's not recommended to be used routinely in ARDS patients. There are several ways to do it. Most famously, the sustained inflation. Just to give the patient, this is the usual parameters he's on, and now give him high pressure level, CPAP level, for a level of 40 centimeter water for 40 seconds, and of course should be paralyzed completely before this trial with careful monitoring for the hemodynamics. He might develop arrhythmias, hypotension, so in such cases abort the recruitment maneuver completely. I think this is the most famous method applied as a recruitment method. There is also what's called sigh breath, التنهيدة, sigh breath. So as you see, these are the normal breaths on the ventilator, and every like 30 seconds, whatever you want, you can set up the thigh presses as you like. Every 30 seconds you can put one single thigh press, which is higher in tidal volume compared with that usual breaths, or higher in the pressure, higher in volume or pressure, according to the mode you are using, volume controlled or pressure controlled. You can apply 3 consecutive sigh presses every 30 seconds, every 1 minute. So it looks like intermittent recruitment continuously over the 24 hours. It's not just single trial for 40 seconds like this. Another way to do it is what's called extended sigh. So we apply the sigh concept, but not on single breath like this, but in an extended way like this. As you notice, this is the PEEP level, and this is the peak airway pressure, and we increase the PEEP incrementally every 2 minutes, and keeping the delta pressure the same. Delta pressure, which is the driving pressure, should be 15, fixed. So start like PEEP of 25 and the driving pressure 15, so the maximum pressure should be 40, and continue escalating like 30 and the 45, 35 of PEEP and 50 of peak airway pressure, and so on, till you reach 45 of PEEP and 60 of peak airway pressure, then go down slowly. This one looks more physiological, and it gives a recruitment maneuver over longer duration, over 20 minutes, but needs some time to be done. It needs at least 20 minutes to be done, and needs expertise and a very well trained person to do it. So whatever the method of the recruitment, either sigh breath, sustained inflation, or extended sigh, which is called sometimes the staircase or stepwise incremental PEEP, there are some complications of recruitment maneuvers. Barotrauma, ventilator-induced lung injury, pneumothorax, very strong possibility. And hemodynamics, arrhythmias, and hypotension. Where are the recruitment maneuvers in guidelines? Studies failed completely to prove that it makes any difference in terms of mortality. It might improve oxygenation in some ARDS patients, and temporarily even, for 4 hours, 5 hours, and then ABGs worsen again. So it's not recommended to be used routinely in all ARDS patients, but you may apply recruitment maneuver in early and severe ARDS in some patients. Now the big debate, corticosteroids. As we discussed in pathogenesis, the fibrotic stage, fibroblast and fibrosis everywhere, and it is inflammatory damage. So that was the principle behind using corticosteroids in ARDS, and actually it was used routinely like 10 years back, but now the practice is changing. It's not recommended at all for routine use in ARDS patients, and according to US ARDS net protocol, they found harm if it's used after 14 days of the onset. Steroids couldn't show any improvement in terms of mortality. So again, it's left usually for the ICU team responsible for the patient. In early and severe ARDS, methylprednisolone might be applied, but most of the guidelines, either in US or in UK, they don't recommend corticosteroid use routinely in ARDS patients. And of course, this is not the situation now with COVID-19 patients, and there is a recommendation from the suspected organization, WHO, to use corticosteroids as if it is the magical medication in ARDS and COVID-19. Inhaled NO. Where's inhaled NO in ARDS management? It's the same. NO is a pulmonary vasodilator, so it redistributes the blood supply all over the lung fields and improves the ventilation perfusion matching. But again, studies prove that there is no change in terms of mortality, and it's not recommended for routine use in ARDS patients. Especially, there are some serious complications from NO usage, like renal failure and rebound pulmonary hypertension after you stop it. So it's not recommended any longer for ARDS patients. Don't use it. ECMO needs more than 10 lectures to be discussed, and this is not the place today to discuss ECMO in details, but we need to know when should I consider ECMO in ARDS patients. If you have severe patient with PF ratio below 150 while he is on FiO2 90% and the Murray score 2 to 3, you can check Murray score on Google, 2 to 3, or PF ratio below 80 on FiO2 more than 90% with Murray score 3 to 4, and of course should be a good candidate for ECMO with no a lot of comorbidities or end-stage disease or something like that, and also uncontrolled CO2 above 80 millimeter mercury with uncontrolled respiratory acidosis below 7.15 is another indication for extracorporeal CO2 remover or ECMO, whatever. If you want to replace the lung function, you can apply VV ECMO, take from the vein and back to the vein. The heart is fine. If you want to replace both heart and lung function, you need to apply it like VA ECMO, take from the vein and back to the artery. There are some contraindications for ECMO, like mechanical ventilation on a very high setting for more than 1 week. Don't use ECMO here because he was prone and exposed to very high levels and toxic levels of oxygen for a very long time. So mostly this lung, there is no hope to be healed again, and there is no place to wean ECMO. We lost this lung. There is no place for the ECMO in such cases. Also, if there is CNS hemorrhage that is recent or expanding, because there is intensive anticoagulant protocol with ECMO. So we need to discuss if there is any contraindication before considering the patient for ECMO. So finally, to recap the options, first step, we need to classify and stratify the patient whether he is mild or moderate or severe ARDS through PF ratio. 300 to 200 mild, 200 to 100 moderate, below 100 severe. For all patients, we need to consider low tidal volume ventilation with the targets mentioned in the presentation. Plateau pressure below 30, driving pressure below 15. And it's quite important to consider both factors, because sometimes you have plateau pressure below 30, but the driving pressure is above 15. So in this case, you need to go down with tidal volume as well. As if the PEEP, for example, is 10 and the plateau pressure is 28. Here, plateau pressure is below 30, but the deriving pressure is 18. This is not accepted, because we have here what's called baby lung, and the aerated normal functioning lung is very small area, and that's why driving pressure shouldn't exceed 15 millimeter mercury, even if the plateau pressure is below 30. So we need to consider both factors, please. If the patient's PF ratio below 150, we need to consider higher level of PEEP. We need to consider paralysis. We need to think about pruning him. If the patient is severe enough with PF ratios below 100 or 80 on FiO2 of 90%, we need to consider ECMO. There are other vent modes to be used sometimes, like high frequency oscillation or airway pressure release ventilation, APRV, and I will dedicate a special lecture for that mode, APRV. It's very important, but again, just to give a summary, it doesn't make any difference in terms of mortality, but it does improve the oxygenation in many ARDS patients, and I'm going to discuss APRV in a short lecture later on. And as we mentioned, corticosteroids, inhaled NO therapy, has no place in the modern ICU practice to be used routinely in ICU patients. We might consider corticosteroids in early and severe cases, but never to consider a corticosteroids very late after 14 days of the onset. This is a summary for the whole lecture. This is a brain map. I hope you found the lecture useful. Thank you very much for listening. If any question, please don't hesitate to write it in the comment. Thank you.